Proceeding to our next talk, we'd like to now invite upon Dr. Swathi Jadhav, who will be delivering the talk on practical utility of AMH and insulin assays.
So next we have a talk on AMH and insulin assays. We know that AMH now include the criteria for diagnosis of PCOD. More and more people are using it. The gynecologists have been using it since long back, and insulin, because of the more prevalence of obesity and insulin resistance, the assays have been used even in some what we call health checkups. So Dr. Swathi Jadhav, who's the director of ENDODIABCON, the Hormone Clinic in Bangalore, will be deliberating on this topic, practical utility of AMH and insulin assays.
A very good afternoon, everyone. Can I have my slides? Yeah. So thanks a lot, Dr. Ganesh, for inviting me for this talk. So as the topic says, it's AMH and insulin, but if I have to compare the two, AMH would weigh much higher in gynecology and endocrinology practice or in any practitioners who are involved in taking care of women's health. Insulin, I might say, is not that important at all, to the extent that if time doesn't permit, I may skip that altogether very happily. So when we talk about AMH, we all understand that it is a marker of ovarian reserve, and so it will help us predict the fertility. So in gynecological practice, it is very true, but it also has got other utilities in the form of, in pediatric endocrinology, to have some differentials in DSDs and to differentiate CDGP from hypo-hypo. But in gynecology practice, we have lot of indications. So when I speak to the gynecologist, I don't think I am capable of talking about the use of AMH when they use it in infertility setups, whether it is IVF related infertility or non-IVF ART settings. They know better than me that how they use AMH in explaining the prognosis, how they predict the ovarian response, and how they individualize the dose of recombinant FSH. So I'm not going to speak on that. I'm going to speak on such common scenarios which come in our clinic, like a 15 years old girl, strong family history of POI, all her family members have undergone POI, premature ovarian insufficiency, at 30 to 35 years of age, and they are worried. Now, what are the chances of this girl getting into POI, and should they preserve her eggs? How to answer that question, and how will AMH helps in that? More common scenario than this are what we routinely see. 32 years old, a very competitive IT professional. She has got a very good career opportunity abroad. She is 32, married since 3 years, but she wants to delay her pregnancy till the time she completes her opportunity and comes back. So can she delay the pregnancy by 3 to 4 years? How do we answer that? And more common is our medical professional. MD has been done, DM has been planned, 1 year for getting into it, 3 to 4 years for getting done. So can the pregnancy be delayed by 3 to 4 years? So how do we answer those questions? Can AMH help there? And this patient, last patient, 23 years old, she was my patient, papillary carcinoma of thyroid, underwent surgery. Now she is planned for radioactive iodine ablation. And we understand that radioactive iodine ablation has got some effect on fertility, not as much as we see in other cancers like alkylating agents and chemoradiation. But she had a peculiar history of undergoing multiple ovarian preserving surgeries for ovarian teratomas. So whether she should undergo RAI, she shouldn't undergo if it is optional, that is another question. Other than that, there can be situations like a 42 years old woman who is a divorcee now, is planning to remarry. And so her question is, how many years am I away from my menopause? How do I plan my life? And in the morning we heard about the potential role of AMH in PCOS diagnosis. So these are the questions which I will try to seek answers for as per the literature. So essentially the outline of my talk would be the utility of AMH in predicting fertility in normal women, not in the settings of infertility, but in normal women whether we can predict the natural menopause, age at natural menopause, oncology and fertility, potential role of AMH in diagnosis of PCOS and POI. So when we talk about that, let's first understand a little bit about the physiology of AMH. So AMH is essentially a glycoprotein peptide, a glycoprotein hormone which is belong to the TGF beta superfamily. It has got this structure where there is an N-terminal prodromedine, and on the C side there is a C-terminal active domain. It is the C-terminal domain which attaches to the AMH receptor, which is a transmembrane receptor, and then there is a series of recruitment of other receptors and SMAD pathways which translocate to the nucleus and ultimately lead to transcription of different genes. They are produced in the females by the small antral follicles and secondary follicles, pre-antral and small antral follicles. Primordial follicles don't produce AMH, and once the follicles get selected for ovulation and the size increases, the pre-ovulatory follicles don't secrete AMH. So it is the pre-antral and small antral follicles which decrease. So in the lifespan of a woman, as these small antral and pre-antral follicles, the number goes down, the AMH also proportionately goes down. And that is how it is reflected in terms of the levels of AMH in males as well as in females. As we can see, the level of AMH at birth is negligible, and during childhood, as the recruitment of primordial follicles to primary follicles begin, the AMH starts increasing and it reaches a peak around 25 years of age, and thereafter there is a steady decline of AMH levels till menopause. In males, it is produced by immature Sertoli cells, and as the name is AMH, its effect has to be there in early pregnancy. So in 8 weeks of gestation, the levels of AMH are highest, and the AMH levels are inversely proportional to testosterone levels in males. So in the lifespan of a male, as the testosterone level increases after puberty, the AMH levels come down. What does it do? Name only is anti-Mullerian hormones, so it helps in agenesis of the Mullerian duct in males. But what does it do in female? Why is it still there in females when it has just to regress the Mullerian duct? So this is the typical cycle where we can see there are primordial follicles, which is the largest pool. Many of them undergo atresia, but some of them get selected in an FSH independent manner to get selected into primary follicles. They will undergo further growth, develop secondary and antral follicles. At this stage is the FSH dependent stage, and under the influence of FSH, some of the antral follicles get selected for ovulation further. What does AMH do? AMH inhibits the recruitment of primordial follicles into primary. So they preserve kind of this primordial follicles. And secondly, it inhibits the antral follicle sensitivity to FSH. So it tries to, it acts like a gatekeeper to ensure that only a single destined follicles get selected for ovulation. Not many primordial follicles get selected, not many antral follicles get selected for further development. So that is shown in the AMH null mice. If you can see, these green dots are the primordial follicles and the yellow dots are the activated small growing follicles. So in AMH null mice, when AMH is not there, we can see as the age passes, the number of primordial follicles get used up, and they are way less than the corresponding normal mice. Not only that, but normally the growing follicles should be limited and should be regulated, but they also get used up a lot, so that ultimately we end up in exhausting the ovarian reserve. Now let's talk about how do we predict fertility in normal women. The kind of questions our medical student and IT professionals ask while they are planning their life. So this is a representative study of around 260 women, prospective study, where they have seen a 25 to 42 years of age, only 2-year study. So they had seen the rate of natural pregnancy without any fertility assistance. If AMH is less than 1.3, then the chances of natural pregnancy are 60%, which are actually 70% when we say the AMH is normal. That means this can be considered as a normal rate of natural conception in young women 25 to 40 years of age. And when the AMH is low, the chances of natural pregnancy are reduced a little, 60 to 70%. But this is very broad. This cannot be used to counsel a patient and give her correct answers to her questions. The low level of AMH doesn't mean that there is no chance of natural pregnancy. In this cohort, pregnancy was seen even with the AMH of 0.16 Ng per ml, which is very low. But having said that, if the AMH is good, with high AMH levels, and if the cycles are regular, that means they don't have PCOS, then the chances of natural pregnancy are highest. Not only one study, but a systematic review, meta-analysis of several studies, including thousands of patients, have concluded that serum AMH levels have poor predictive value for natural pregnancy, not in infertility settings. And any woman coming with low AMH, if she has not tried and has not been infertile, just asking for the fertility potential, it is not associated with reduced fertility. So to answer these two ladies that is it safe to delay pregnancy, in other words they are asking for the fertility potential. So here AMH will not give us a very correct answer as such. It can be a weak predictor, lower the AMH level, lower the chances, but low AMH levels will not be indicative of decreased fertility. So we can't answer these questions perfectly based on the AMH level. The question is why it is not able to predict fertility properly. It's its job to predict ovarian reserve. So why it doesn't do? The answer to that is that it's not just the quantity of oocytes which determines fertility, but it's also the quality, which probably is not reflected by AMH. There can be other factors also, extra ovarian factors like uterine, metabolic, other factors which can affect fertility. But two pertinent questions are, if a lady comes with low AMH, we want to know whether it is really low. That means it is lower than normal. So we want to know what is the normal range of AMH for explaining that to the patients. And also there is a huge impact of assay variability there. So if we study the normal range of AMH, a lot of data has come from the fertility centers, and we can see that the normal levels of AMH are very varying. I mean very broad range of normal AMH, and it is even to the lower limit of normal also it touches the normal AMH range. But one can argue that these are infertility centers data, they may not reflect the normative data in normal population. So this beautiful study from China, lot of patients, around more than 5,000-6,000 patients, and they are normal people, normal girls, they are not from infertility centers, and right from birth till menopause they had seen. Even here if we see in any given quartile, if we see the range of AMS, lower limit of normal versus high, it's a huge range. It's not a narrow range as such. And as per them, in the reproductive age women 19 to 50 years, the lower limit of AMH can be as low as 0.5 also, which can be normal. So then the second question comes the assays. So when we talk about AMH assays, we have to talk about what exactly we are measuring in the serum. In other words, what are the circulating forms of AMH? AMH is not a single molecule homogeneously which circulates, but there are several forms of it. This AMH is circulated in the blood in the form of pro-AMH molecule, with there are two sites where the division happens. And when the division happens at the most common site, this C terminal or the active form, it becomes non-covalently attached to this molecule, and this is the molecule which circulates in most abundance. The free form, the active form, doesn't circulate in the blood, but there, depending on where the cleavage is happening, there are different molecules of AMH which are circulating in the blood. And when we talk about AMH assays, there are capture antibodies and there are detection antibodies which can target the different areas, and as such there may be differences in the assays which detect different molecules. In India, the most commercial labs which are using AMH are these two automated commercial assays, either Beckman-Coulter or Roche. These are the two most commonly used assays in India. But let's see if there are different assays, what is the comparison between the performance of these different assays. So as we can see that they are not the same. There can be situations where one assay may give 1, but the other assay for the same sample may read as low as 0.76, that is 24 to 25% lower than one assay can give as compared to others. Not only that, there can be 30 to 40% increase levels also. So depending on the assay used, the same sample may give different AMH results, which again makes us difficult to interpret AMH when they are done successively in a patient. Coming to the next question, that can AMH help us in predicting the age at menopause or time to menopause? Again, this was a 14 years follow-up study, around 400 patients, and they had done that the different age groups, 30 to 40 years, 40 to 45, more than 45, and if a woman comes with different AMH levels, can we tell her what is the time to menopause for her? For example, my patient was suppose my patient is 35 years of age and she comes with a AMH of 0.2. What can I tell her if she asks me how much time she has for her menopause? So we can see here at 35 to 39, if the lowest quartile less than 0.2, the range is very wide. 3 to 12 years is the age to menopause, but nevertheless these are 95% confidence interval. At the max, I can tell her that 95% of the time you will not have menopause till 3 to 12 years of age. Whether you fall in 95 or you fall in 5% outliers, we don't know. So that way, if we answer this question that how much away a patient is from her menopause, we can say the performance of AMH is fair. It can be useful, but we can't give the exact age of menopause for a patient depending on her AMH levels. Coming back to how can AMH help us in predicting the POI, premature ovarian insufficiency. Again, good number of patients, but this is a retrospective data, and they have defined the POI in the form of FSH levels. FSH 11 to 25 pre-POI, 25 to 40 early POI, and more than 40 is POF. And as we can see, the AMH level is very different as compared to normal levels. And as we can see, if it is POIs, it can be as low as 0.07 Ng per ml. So they had given that for prediction of POI, if AMH cutoff is 0.25, then sensitivity and specificity for diagnosing POI or predicting the onset of POI would be around 90%. So my patient, 15 years old, whether to predict POI, at this age it's not possible because she has not yet achieved the peak age at which the peak AMH is achieved. So here I can't predict, but otherwise in normal women between 25 to 40 years of age, if they come, then AMH is very good in making the diagnosis. But predicting that now this is the AMI, what is the chance of getting into POI in future next 3 to 5 years, that I can at the max say it is fair. Again, for individualized answers, I don't have those kinds of answers. Regarding PCOS, in the morning only we have heard, if the picture is like this, if there is oligoanovulation, if there is hyperandrogenism, if there is a suggestive clinical scenario of obesity and all, then I don't need AMH for making the diagnosis. It can at the most be an adjunct to the diagnosis. But as the proposal is, it can act as an alternative to polycystic ovarian morphology on USG. It has been proposed to be included, but the problem is at what cutoff. Literature says that the cutoff can be varying across different studies, and as of now we don't have a consensus for the cutoff, and that's what is reflected in the older guidelines, in 2018 guidelines, that it should not be used. Very quickly going through the AMH in oncology, that whether the serum AMH level can predict the impact of, say, ovarian conservating surgeries like ovarian endometriomas and all in guessing about ovarian reserve. So pre and post procedure AMH are definitely useful. But more common now are the oncology setup, that if somebody is undergoing chemotherapy and radiation therapy, can post treatment AMH be used to evaluate the ovarian function and the fertility. So it is said that it can be a predictor for continued amenorrhea if it is very low, but fertility, we need further studies to say at what level of AMH I can tell a patient of cancer survivor that she can't conceive. And similarly, it is for if the pre-treatment AMH level is there, then whether it can help us in predicting the restoration of menstrual cycles after treatment. For that, again, for restoration of menstrual cycles, we can still predict, but for fertility, we can't. Insulin, as I said, if the time doesn't permit, I will not talk about it, but then more important than insulin assays are the clinical parameters, acanthosis, obesity. Very neglected aspect is family history of diabetes. If family history of diabetes is there, I don't need any insulin assays. So here I would like to conclude that insulin may not be, but AMH in the kind of predictions which are there for these parameters, not in ART treatment, they can give us a general idea, but there are no individualized answer. In case if the AMH is very low, for any of these, if the patient comes to me and asks me the questions whether I can plan pregnancy or not, whether I can delay it or not, at the max I can say if it is very low like 0.7, 0.8, I can't tell her that you have this chances of not getting pregnant or menopause or whatsoever, but I can say if you have to any time in your lifetime, if you are going to plan pregnancy, plan it soon, don't waste time. Thanks.
Thank you, Swathi, for that excellent talk. So I think still further studies are out. AMH is pretty useless. I mean, maybe we cannot tell useless, but not a very good test for other than infertility probably. If at all we are doing AMH assay, when do you do it? Is it related to the cycle or time of the day?
So AMH does not get affected by the menstrual cycle. I mean, in all phases, at the most variability of AMH is 10 to 11%, not more than that. So that doesn't translate into any clinically meaningful differences. So you can order AMH any part of the menstrual cycle.
Any
Yeah, so on OC pills, the AMH will be falsely low and it remains low till the time OC pills are continued, but most of the studies have shown that it will go back to baseline levels within 2 to 3 months after stopping AMH. So after stopping OC pills. So you should order AMH 3 months after stopping the OC pills.
So in the paucity of time, thank you Swathi for that excellent talk, and thank you organizers for giving us the opportunity.
Thank you, Dr. Swathi Jadhav.